Hello, folks. My name is Dr. Erik Wilson, and I'm going to talk today about the role of endoscopic sleeve gastroplasty, or ESG, as a weight loss procedure. I really think that the goal of minimally invasive surgery is twofold philosophically. Number one is to make it better, so we do a better job and don't have to convert to open operations. And then, of course, make it more, meaning making it more minimally invasive. So ultimately, fewer incisions or no incisions. And a lot of bariatric development is being put into trying to reduce the invasiveness of bariatric surgery even further. Obviously, we have a whole bunch of patients that are not getting any type of treatment that are obese. We know this is a common problem. And so endoluminal options potentially could help fill that gap. There's a whole bunch of endoscopic bariatric therapies that are out on the market or being actively developed, and endoscopic sleeve gastroplasty is one of those. There's a whole bunch of patients that have a BMI range between 30 and 40, don't classically qualify for surgery, but still have significant comorbidities from their obesity. There's about 70 million in the United States. And so these endoluminal therapies can fill in a very important gap. So the overstitch device, or endoluminal suturing, which is the device we utilize to do ESG, began as a concept in 1999 with the first prototype called the Eagle Claw being developed in 2002. Licensed from Olympus, and then ultimately a company was formed called Apollo. That was founded in Austin in 2006. The first human device, clinical device, was developed in 2010 as a large device, as you can see up here. And then the second generation device, which was a simpler device and easier to utilize, came out a year later. And this device is utilizing for suturing. It's basically a suturing device on the end of a scope. You can grab tissue with a helix, which is a tissue grasper, and then fire a needle across it, and then reset the needle and fire again. So it shuttles the suture and the needle through a anchor exchange mechanism, and it allows you to take as many bites as you want to, and that's how it works. It's used for closing defects. It's just a sewing machine. In the bariatric space, it's been utilized. Initially, we were utilizing it for gastric bypass outlet revisions. You could go and tighten up outlets. You could reduce pouches. And so that's where a lot of bariatric surgeons cut their teeth on this device and this procedure, utilizing the flexible suturing to reduce outlets and reduce pouches. There's a whole bunch of different types of suturing techniques that were developed at the time. But even before that, there was a device called the barred endocinch device, which was more mucosally based using suction. And it was utilized as a technique to cause primary reduction of the stomach or endoluminal suturing. So this was probably the first indication of this, done in 2008 by Roberto Fogel. And he saw pretty good weight loss in patients, especially in patients with lower BMIs, even with a mucosally based device. This went on to be utilized, this went on to be utilized in what was called the TRIM trial, with 18 patients being performed on it with this mucosally based device using the barred endocinch, and 14 were followed out to 12 months. The mean BMI was 38. Procedure time took a decent amount of time, but there were no adverse events, and the weight loss was about 11 kilograms or 4 BMI units. At the same time, around the development of these types of devices, laparoscopic gastric plication came on the scene as a competitive procedure with sleeve gastrectomy. And a lot of people thought at the time that this might displace sleeve gastrectomy because you didn't have to use a stapler. But this is an interesting article that showed, there were two basic ways of doing it: either taking down the greater curvature and pleating the stomach itself, or not taking down the greater curvature and doing it anteriorly. And what you see with those two different techniques, different types of weight loss results. And when you didn't take down the greater curvature, you had less weight loss, which is what you would expect when you do endoluminal procedures. You should not expect as good of weight loss as if you did a full mobilization of the stomach or, a sleeve gastrectomy. So the expectation around this procedure should never have been that it would be as good as surgery, and is probably better indicated in patients with lower BMIs as it relates to durability and weight loss. We did the original procedures of this clinically with the overstitch device in 2012. So that's where it started to begin. We did 4 patients back then. We had a BMI at 6 months drop from 33 down to 27, about 17% total body weight loss, about 15 kilograms. And it was enough information to keep pursuing this. The basic way of doing this is really 3 basic steps. You put a scope down, you then identify the greater curvature, and you want to mark out the greater curvature because you're protecting the lesser curvature. When we did this, this was developed by both gastroenterologists and surgeons, but the surgeons were on record saying we really need to protect the lesser curvature so we could do revisional procedures, potentially do bariatric surgery if the patients were to need it down the road, if they were to regain weight, because the durability may not be as good. And so that's how it was set up, where you do APC marking to protect the greater curvature, and then you stay on the greater curvature and then do a series of sutures, either in an N pattern or a U pattern, to placate down the greater curvature. And then you reinforce that and basically tighten that up with additional sutures. So this shows how you cinch it down. So again, you mark, identify the greater curvature, suture within those markings, and then go and reinforce to any gaps that you see with inner row sutures. So this is what it looks like by cartoon form. After you've completed it, you tend to have a little bit of fundus left because you can't get the device all the way into the fundus to completely suture down the fundus. And you want to be careful with the fundus, obviously, to not cause bleeding from the short gastrics. What does it look like post-plication? Well, it reduces the caliber, obviously, of the stomach. It looks like kind of a bumpy sleeve, but obviously there's nothing resected. And it foreshortens the stomach as well. So if you measure from the esophagogastric junction to the pylorus, you'll see that it's significantly shorter, usually between 8 to 12 centimeters shorter after the procedure. What are the patients that are best served for this? Probably BMIs between 30 and 40. I really prefer the patients in the lower BMI range, between 30 and 35. It's not an absolute contraindication that they haven't any previous stomach procedures, but that's something to obviously consider. They shouldn't be done in probably patients with large hiatal hernias or Barrett's. It is not a sleeve gastrectomy, but you're trying to make it look like one, but it doesn't function the same way. And it is designed to be revisable, so you need to focus on the greater curvature and protect the lesser curvature. This is one of the original patients we looked at about a year out. And what you see is that it starts to open up. Some of the sutures start to loosen, but there is still thickness along the greater curvature, and the sutures still seem to be in place and doing something. And then the fundus is preserved to some degree when you get to the top. So it does slowly open up over time, but the effect seems to last for over a year and probably closer to 2 to 3 years in most patients. So the next thing that was done was something called the PROMISE trial out of 4 sites in the United States. This was done in 2013. It's basically 20 patients that we looked at, 5 patients at each center, and we're looking at basically safety and basic efficacy. And we saw patients that were followed out, and we saw no severe adverse events, some nausea and vomiting, postoperative pain in a small number of patients. And the weight loss was adequate. Again, you saw about 15% total body weight loss at 1 year. In Mayo, 2 gastroenterologists, Dr. Abadé and Dr. Gastat, were also doing these procedures concurrently in the United States, and they saw similar weight loss. So this kind of got the ball rolling, and we started looking at growing the procedure in other centers. It doesn't work like a sleeve gastrectomy. You're not resecting anything. And what we've seen, Dr. Abadé did some good work on this, where he looked with gastric scintigraphy to see what's actually happening. Patients feel fuller quicker, and they eat less, and so they are satiated quicker. But they also have a satiety effect because of delayed gastric emptying. So a gastric scintigraphy, food is retained in the fundus for a longer period of time, and that prevents patients from seeking additional meals. It's probably one of the mechanisms for this, which is obviously different than a sleeve gastrectomy, where they've improved gastric emptying and stimulation of intestinal factors with that. So this is a large multi-center trial of 250 patients, retrospective, looking at 24 months follow-up to look at this procedure. It was 3 centers in Spain, Cornell, and Mayo. And what they showed is at 6 months, 15% total body weight loss, and at 18% total body weight loss at 2 years, but that was about a third of the patients. Again, comparing the weight loss between the centers, it was comparable between centers. Again, showing the weight loss, total body weight loss approached 20%, but we had lots of patients that were not followed far enough out for that follow-up at 18 months and then 2 years. But what they did see is who were the patients that had good weight loss. If you had more than 15% total body weight loss at 18 months, were there any factors that played into it? About 2/3 of those patients did have that level of weight loss. And what you would see is the patients that had good weight loss at 6 months also had good weight loss at 18 months. And so if the patients were not doing well at 6 months, that probably means the sleeve was opened up or had relaxed, and the sutures were probably not placed as well, or the patient did not respond as well to the procedure. And it's worth looking at the anatomy again early as opposed to waiting. It also foreshortens the stomach. You can see that by measurements. It affects comorbidities. This retrospective data is early, and we need a lot more of it, but it does show improvement in hemoglobin A1C and blood pressure. As far as adverse events in this series of about 250 patients, 38% had some self-limited nausea. It usually lasted about 2 days. About 27% had mild to moderate abdominal pain that also lasted about 2 days. So those are pretty common events. But serious adverse events did exist, about 2% of them. Peri-inflammatory fluid collections that required percutaneous drainage in 2 patients, a pulmonary embolism in 1 patient, a hemorrhage after a splenic tear in 1 patient that did not require surgery but was required expectant management in blood, and then a patient with a pneumoperitoneum and pneumothorax requiring a chest tube placement. So this is full thickness. It's stronger than some of the other devices out there that we used for suturing before, and it does go through the wall. So you can see with this graphic and this video that this helix will go through the wall of the stomach and can grab other tissue. It can grab the peritoneum, you can grab the diaphragm. So you have to be careful on how you utilize it when you're working with the device in order to avoid the bleeding and fluid collections. There is another version of plication, the Pose procedure, which is a different device that has been out there. And it basically performs single plications, and you can't do multiple bites with it, but these are thick, fairly durable plications. And the original Pose procedure that's been out there for many, many years basically focused on reducing the size of the fundus and the antrum as well. So it was a less aggressive suturing technique, but had pretty good initial results, especially outside the United States. And then there was a trial called the Essential Trial where they randomized patients to medical therapy versus the procedure. And what they found was pretty modest weight loss, about 5% total body weight loss for the treatment group versus 1.3 for the sham. And so that was it was significant, but wasn't significant enough to meet its clinical endpoints. And so they went back to the drawing board. There was another open label trial done where they randomized patients, but the patients knew about it. They weren't blinded, and they had better weight loss, 13% total body weight loss versus 5% for diet and exercise. So basically what they've done with this device is gone back and redo the suture pattern with a more aggressive pattern that more closely mimics the ESG pattern that we're doing, and that's underway right now. What about if you get an ESG, can you go back and do something else? So of course it was designed that way when we started, but if you wait far enough, usually 2 to 3 years, you can see that the sutures will open up enough where you can safely do a sleeve or a bypass. And I've had my own patients where I've done converted them to sleeves and bypasses and have been able to do it safely. This is a stomach resected from one of the original Panamanian patients. One of my colleagues down in Panama had one of the patients present to him 4 years later with weight regain and wanted a sleeve gastrectomy. He scoped the patient. He found that the plications were far enough away from the lesser curvature that he could safely do a sleeve gastrectomy. You can also cut these out endoluminally or laparoscopically if you need to. Larger series that have been done, Dr. Al-Qahtani has done 1,000 of these and reported that. And he basically saw similar weight loss, about 15% total body weight loss at a year in his series. He had 24 patients of these 1,000 that were readmitted, 8 for abdominal pain, 7 for post-procedural bleeding. 2 of those required blood. 4 perigastric collections with a pleural effusion, and 3 of them went percutaneous drainage. And then 8 patients ended up being revised to sleeve gastrectomy, and 5 had a redo ESG. And there were no mortalities and no emergent interventions. How does it compare to band or sleeve gastrectomy? This is the study out of Cornell, which looked at laparoscopic sleeve gastrectomy versus gastric banding versus ESG. And what you basically see is better weight loss with sleeve gastrectomy. The ESG more closely mimics adjustable gastric band, but the post-procedural morbidity is lower with ESG than laparoscopic sleeve gastrectomy. This has also been done at Johns Hopkins. where they looked at sleeve gastrectomy versus ESG. And again, you see better weight loss with sleeve gastrectomy than you with ESG, but you had lower morbidity with ESG, and you had less reflux with ESG. So we're in the middle of a trial called the MERIT trial, which is a randomized trial of medical weight loss versus endoscopic sleeve gastroplasty. There's 8 centers across the country that are doing this, half gastroenterologists and half surgeons. And basically, we're taking patients with a BMI between 30 and 40, randomizing them to medical therapy with intermediate term or intermediate intensity medical supervised weight loss with monthly visits versus endoscopic sleeve gastroplasty. And then we're crossing over the medical supervised patients at a year and allowing them to get the ESG. We have now enrolled all the patients. We're finishing up the crossovers, and hopefully we'll have this data reportable next year. We're also have included a significant number of hypertensives and diabetics to look specifically at those patient populations to see how we can improve those comorbidities. So ESG right now is at about 10,000 cases performed globally. There have been about 25 or a quarter of these have been done inside the United States, so most of them are outside the United States, but half of them performed by surgeons and half by gastroenterologists. There's about 85 centers in the U.S. that are doing them, and majority of those are community programs. So to summarize, endoscopic sleeve gastroplasty is a well-suited procedure for patients who don't qualify for surgery and are frustrated with medical weight loss. It does require a suturing skill set that's trainable to surgeons. Gastroenterologists can learn it too. And it can have a pretty low complication rate, but it's not zero. It seems to have intermediate term durability for over a year, probably closer to 2 to 3 years, but it's probably not significantly durable out past 5 years. But it also is revisable and convertible to other bariatric operations in well-educated surgical hands. And I appreciate y'all's time. I'm happy to answer questions in the question and answer session. Thank you.